your physical. All right, so we'll get on to our speaker. Our speaker today is Dr. Baha El-Sufi. He did his surgical training at UMass, his cardiothoracic surgery training at Oregon Health Sciences University, and his pediatric congenital heart surgery training in Toronto at the Hospital for Sick Children. Dr. El-Sufi spent some time after that in Saudi Arabia and later located to Emory University and the Children's Healthcare of Atlanta. He spent 6 years there before joining us in 2018 as the Chief of Pediatric Cardiac Surgery and the co-director of the Heart Institute at Norton Children's Hospital. He is also the Director of Heart Transplantation and has authored over 100 peer-reviewed articles on congenital heart disease. So I'd like to welcome Dr. El-Sufi, and I'll turn it over to you for your presentation.
Thank you, Mark, and good afternoon, everybody. It was suggested to me that I speak about the single ventricle anomalies. Obviously, these are very challenging patients and complex patients, and it's natural that many don't feel comfortable taking care of those patients, as the poll has indicated. We have a very large experience with those patients at Norton, and it's a special interest of mine, and probably I've written more than 50 papers alone on single ventricle anomalies, so it's very intriguing to me. Obviously, you can write books about single ventricle anomalies, so you can't summarize it in one talk for sure, but I'll try to touch on some helpful introduction on how we manage those patients, then probably focus more on what the general pediatrician cares about more, which is the long-term management of those patients and some complications that they have. I'm gonna try to share my screen now. Are you seeing my screen now?
Yes.
Okay, good. So single ventricle anomalies are not uncommon. They're more than 10% of all the congenital heart defects. The morphologists and the pathologists continue to fight and debate for the proper definition, but for me, all I care about is that these are the hearts that we treat with single ventricle multi-stage palliation strategy. And most of those patients have hypoplastic ventricles, small ventricles. Many have small mitral valve and tricuspid valve. However, some of them have what we call functional single ventricle. They have two ventricles, but they have to be treated with a single ventricle strategy. And I'll talk about those later in a few minutes. So I'm gonna give an example of patients who have hypoplastic ventricles or hypoplastic atrioventricular valve. And the most common single ventricle anomaly is hypoplastic left heart syndrome. And as you can see here, the right side looks normal. However, the left side, you can see the ventricle is very small, the mitral valve is small, sometimes you have mitral atresia, and there is aortic atresia, and you see that small structure is the ascending aorta, which is diminutive, and there's coarctation of the aorta and hypoplasia of the aortic arch. So hence the name hypoplastic left heart syndrome. So everything on the left side is small. Another problem is tricuspid atresia, and that's probably the second most common single ventricle anomaly. And unlike the previous defect, the left side is normal. However, because of the tricuspid atresia you see here, the right ventricle is very small. And I hope that you're seeing my arrow that I'm using, but the right ventricle is very small, and the blood flow to the pulmonary artery comes from the ductus or from the hole here in between the two ventricles. So in this defect, the small ventricle is the right ventricle. Another example is pulmonary atresia with intact ventricular septum, and similar to the previous defect, the right ventricle is very small in this patient. Patients with atrioventricular canal or atrioventricular septal defect usually are balanced, where the two ventricles are equal size. You have the atrial septal defect, ventricular septal defect, and the common valve. However, if you have one smaller ventricle and smaller component of the valve, like for example here, the left side, or here the right side, this is what we call unbalanced with atrioventricular septal defect. And those patients also will require single ventricle palliation. I thought I'll mention also double inlet left ventricle, and this is a relatively common defect, where, as the name implies, the left ventricle is good and it receives its double inlet, so it receives both the mitral and the tricuspid inflow. However, the right ventricle is small, and in this disease, the left ventricle is normal, and this is hypoplastic right ventricle. And sometimes we have something called double outlet right ventricle, where both vessels come out from the right ventricle. And most of the time, those defects are two ventricle patients that we can repair the heart. However, some of them will have small left ventricle and they need single ventricle palliation. So these are the most common types or morphologies of cardiac anomalies requiring single ventricle palliation. As I mentioned, sometimes you do have two ventricles. However, you cannot do the repair and you have to do the single ventricle palliation. For example, this is the patient where the valve on the right side is straddling, and that means it gets chordal attachment from the other ventricle. So I cannot close the hole here, and therefore I'll have to do single ventricle palliation. And sometimes this is a double outlet right ventricle, where usually the hole is close to the vessel, so I can close it. However, if the hole is big or uncommitted, non-committed, like this, we cannot do biventricular repair, and we have to do single ventricle palliation. And some hearts have very complex anatomy that we need to do single ventricle palliation. So as I introduced to you, there are different types of pathologies that require single ventricle palliation, and they differ. Some of them have dominant left ventricle, some of them have dominant right ventricle. The pulmonary blood flow is different. Sometimes they have unrestricted pulmonary blood flow, some of them have pulmonary stenosis, some of them have severe pulmonary stenosis. And similarly, the systemic flow, some of them have aortic obstruction and some of them don't. And some of them have transposition of the great arteries, and that might be important. And I thought even though that probably is too much information for the general, however, the reason I want to show that is that if you have tricuspid atresia or double inlet, it does not necessarily mean that you have pulmonary stenosis, because if you have, for example, double inlet left ventricle on the right side, and the aorta comes from the left ventricle as normal, then there is no obstruction of the aortic flow, but the pulmonary flow is obstructed because it comes from the small ventricle. However, if you have on the left side a transposition of the great arteries, so even though the left ventricle is a good one, but the aorta is the one that has restricted flow, and this patient might require some different surgery. So the reason I wanted to talk about those different lesions, because of those variations, the initial palliation type is different, and that's different based on the anatomy and physiology. Sometimes you hear us saying we did Norwood, DMSK stencil, shunt, band. So what determines what kind of operation do you do? And all those operations are different. However, the goals are the same. And the principles for single ventricle palliation for the first stage are the following, as you can see. These are the most important principles. We want to guarantee that there is no obstruction to the flow to the aorta. There is no obstruction to the pulmonary venous return. And we need to have stable source of blood to the pulmonary arteries without excessive pulmonary blood flow. So if we look at some examples that have obstructed systemic outflow, and For example, this is the hypoplastic left heart syndrome that I talked about. Obviously, there is obstruction of the systemic outflow tract. So how do we treat those? And this is, again, to introduce to you again what are the common names of procedure that we do. So since the aortic valve is obstructed and the right ventricle is the good ventricle, so we want to make this ventricle the systemic. So we take the pulmonary artery and we connect it with the aorta. And this is called Demis-K stencil operation. You'll hear that a lot. And if we have to also correct the aortic arch and augment it, and then we connect those two together, so this way the blood flows from the right ventricle through the pulmonary artery, but now this time it goes to the aorta. And that's called the Norwood operation. And now since we got rid of the pulmonary artery to the aorta, we need to provide some source of pulmonary blood flow, and that's going to be either a BT shunt or what we call an RVPA Sano shunt. You'll hear that a lot. And this is basically the Norwood operation. Another way to deal with those patients, sometimes you hear that they had hybrid first stage operation. So this is a patient with a hypoplastic left heart syndrome. So what we do, we want to provide adequate flow to the aorta, so the interventional cardiologist will go and stent the ductus, will keep the ductus open. This way the blood goes from the pulmonary artery to the aorta. And if we add to it pulmonary artery band to restrict the flow to the pulmonary arteries, we have the same physiology like a Norwood operation. This is an alternative to the Norwood operation for treating those patients. Now, this is a different problem now. These are, like I just showed you, tricuspid atresia or pulmonary atresia. Those patients don't have any problem with the systemic outflow tract because the left ventricle is good, the aorta is good, there's no coarctation. Everything is good. What they have, the problem that they have is low blood flow to the pulmonary arteries. They are depending on the ductus right now to provide the flow to the pulmonary arteries. So how do we treat those patients? Either we do the modified Blalock Tussick shunt, which is putting Gore-Tex tube between the innominate artery and the pulmonary artery, or we go in and stent the ductus and keep that ductus open. This way the blood continues to flow to the pulmonary arteries. Now, this is another example of patients who have excessive pulmonary blood flow. For example, this is a patient with double inlet left ventricle. However, this patient has a transposition of the great arteries. So the vessel that comes out from the good ventricle, the left ventricle, is not the aorta, it's the pulmonary artery. So that means the pulmonary artery has a lot of flow while the restriction is in the aortic valve. So what can we do? We don't want this patient to continue to have excessive pulmonary blood flow. They'll go into edema and they'll develop pulmonary vascular obstructive disease. So the way to treat those patients is to band the pulmonary artery, tighten it, this way increase the resistance and push more blood flow to the aorta. So again, the first stage palliation might be a Norwood operation with BT or a Sano shunt, might be a hybrid first stage palliation, might be BT shunt or a PDA stent, might be pulmonary artery band. About 10% of those patients have enough pulmonary stenosis that they have balanced circulation, and we really don't need to do any first stage palliation. Their first operation is around 4 to 5 months of age, which is the Glenn shunt. And in addition to that, we might need to do whatever is necessary. If they have total anomalous pulmonary venous connection repair, we'll have to treat it. And very, very rarely nowadays, we'll do primary heart transplantation to those patients. So what are the first stage palliation outcomes? The national registry at the STS showed that Norwood is around 15 to 16%. The BT shunt for single ventricle is also about 15 to 16%, and pulmonary artery band is about 10%, and that's a hospital mortality. So it's still substantial for what we do. However, there are some centers that have achieved single-digit mortality in the Norwood and BT shunts. in single ventricle, and we're very proud to be one of those few centers. So what are the risk factors, however? And I've pulled some slides from multiple papers that I've done. And you can see prematurity is associated with worse outcomes, and mainly in the early mortality, so mainly hospital mortality. Low weight also is a risk factor. Patients who have genetic conditions or extracardiac anomalies, as you can see in this image as well, they have higher early mortality. And patients who have heterotaxy syndrome also are associated with higher operative mortality. The factors that I talked to you about were the patient-related factors. However, there are also anatomic factors. If they have associated anomalous pulmonary venous return, if they have restricted atrial septum, if the good ventricle has bad function, if the good valve is leaking, if they have very small ascending aorta, if they have small pulmonary arteries or pulmonary atresia, all of those have been found to be risk factors and associated with higher operative mortality following the first stage palliation surgery. And underlying anomaly does play a role. Overall, if you have to pick one, I would pick double inlet left ventricle. That, in addition to tricuspid atresia, they are associated with the best outcomes. The worst outcomes come to those who have unbalanced AV canal, pulmonary atresia, intact ventricular septum, and maybe a little bit less than that, hypoplastic left heart syndrome. So, now I'm done with probably like the complicated stuff. And most of you as general practitioner, you don't have to deal with that, with whatever I talked to you about till now, because this is starting from birth until they're ready to be discharged. However, once they're discharged, you start dealing with those patients. And what we found that there is high interstage mortality, which is defined as death that occurs following hospital discharge from the first stage palliation and prior to the second stage operation. Traditionally, it's been 10 to 15%. And the most common reasons include shunt thrombosis or cardiac steal and arrhythmias. However, there are some non-cardiac problems that have been identified, such as aspiration, dehydration, infection, or end organ problems. This is a study that I published, and you can see that I'm excluding hospital mortality. So these are only the hospital survivors. And you can see as they progress, this is over 12 months following their discharge. Few of them in orange will get transplantation. They start progressing in green towards receiving the second stage operation. So by 1 year, more than 80% have received the Glenn. However, you can see that about 10% have died without even reaching the Glenn operation. So the interstage continues to be about 10%. The risk factors that I identified in that study, it's a busy slide, but basically what I can show you, the weight, prematurity, genetic syndromes, all continue to be risk factors for mortality, even after hospital discharge. In addition to that, those patients who spent long time in the ICU following the first stage palliation are more likely to die before receiving the Glenn. So some of those factors are not modifiable. We can't change the low weight at birth. We cannot change the prematurity. We cannot change the genetic syndromes or the extracardiac anomalies. Some factors are clinical. So they struggled after their surgery. They have long ICU stay. They might go home, but they have some neurological problem. They might have aspiration, GI discoordination, or some, borderline kidney dysfunction. All of those are risk factors. However, the more potentially modifiable problems include residual lesions. So if they develop aortic arch obstruction, pulmonary venous stenosis, arrhythmia, AV valve regurgitation, pulmonary artery obstruction, shunt stenosis, PA band problems, all of those, we might be able to intervene and prevent a bad outcome. Therefore comes the interstage home monitoring system. Many programs have adopted that, and we definitely have very strong home monitoring surveillance system in our patients following hospital discharge from first stage palliation. We monitor growth, feeding, vitals, temperature, saturation, and other important parameters with the aim to identify the red flags. And if we identify those, we bring the patient in to assess them. We might even admit the patients with the goal to early detect and treat any medical issues or residual lesions. And we have, as did others, proven that a strong interstage home monitoring system has decreased the interstage mortality to around the 2% range right now, which is a very important addition to the care of those patients. So how do we do it? We rely on extensive family education. We provide home nursing if needed. We have a single ventricle team that is specially taking care of those patients on 24/7 basis in our hospital. The family have a hotline. They can always reach this team. The team will preemptively call this family every few days to check on patients. We have very low threshold to admit. We have a certain criteria that will convince us to admit those patients. We schedule close follow-up and imaging visits to our clinic, and we schedule the cath lab before discharge. And now we have the iPad that we are providing to our families, where they enter data, and we are able to continuously monitor what's going on and look at the changes. And this is an example of a patient for the saturation, body weight. We can look at the trend. We can look at what's going on, and that has improved our ability to detect problems and address some of them, and again, decreasing the interstage mortality. So now that we've done the first stage palliation, we want to go to the second stage. We cannot keep them in the first stage, because what those patients after this first stage have what we call the circulation, parallel circulation. So the blood comes to the heart. There's only one ventricle. The heart has to pump it to the aorta, and through the shunt, either it goes to the lungs or it goes to the body through the aorta. And what determines how much goes to the body and how much goes to the lung is the vascular resistance. So we would like to have balanced flow, so with the blood that goes to the body equals the blood that goes to the lung. However, that's not always the case. That's why we have what we call parallel circulation, where the lungs and the body are fighting for their share of the blood. And if the lungs get too much, then the body is getting too less than required, and you can get necrotizing enterocolitis, you can get renal failure, and you can also, obviously, with the lungs getting too much, you can get heart failure. So we want to eliminate this physiology, and we can do that when we reach the second stage, when we do the Glenn shunt. So most important accomplishment is that we can get rid of this parallel circulation. Also, we can get rid of the shunt and the band. So the band can increase the afterload, while the shunt increases the volume load. So by getting rid of those, the heart is in a happier place. And we have an opportunity to address any residual lesion. So how do we do it? There are different operations, but most of the people will do the Glenn shunt, which is taking the superior vena cava, disconnecting it from the right atrium, making an opening in the right pulmonary artery, and connecting that superior vena cava to the pulmonary artery in an end-to-side fashion. And obviously, we get rid of the shunt here. And that's called the Glenn bidirectional cava-pulmonary connection. So how is the physiology here? Now, the inferior vena cava continues to go to the heart. However, the superior vena cava goes to the lungs. The heart only needs to push the blood to the body. So there's no more parallel circulation. The lungs and the body are not competing for the blood flow. So we have eliminated the parallel circulation, and the patients are in much better place. And actually, the risk of mortality following the Glenn is much decreased compared to the mortality, the interstage mortality between the shunt or Norwood and then subsequent Glenn. And home monitoring has not been proven to be very effective after the Glenn, and it's not necessary. Now, eventually, we need to reach the third stage, and we do that around 3 years of age. And the goal at this stage is to increase the pulmonary blood flow, because it's only coming from the superior vena cava. As the kids grow, as you know, the head to the body ratio decreases, and therefore the blood supply to the lung is gonna decrease, and the patient becomes cyanotic. In addition to that, because the hepatic factor, which is some product from the liver that nobody has identified yet, but it is anti-angiogenic factor. Once it reaches the lung, it prevents the formation of AV malformation. So if you don't provide the hepatic factor by including the IVC flow, the patients develop AV malformation and become cyanotic. So that's the purpose of the Fontan. And there are two types. There is something called lateral tunnel, and there's something called extracardiac Fontan. And most of the people will do extracardiac Fontans nowadays, but some centers continue to like to do lateral tunnel. But what's either way, this is the circulation that we have provided. This is the physiology that we provided after the Fontan. And it's like a normal, almost like a normal in series circulation that everybody with normal hearts have. Now the superior vena cava and inferior vena cava both drain to the lungs. The lungs then send the blood to the heart, and the heart will send it to the body. So it is in series circulation, and you can actually achieve normal saturation after the Fontan operation. However, Fontan is not the end of the road. Although it's a third stage operation, unfortunately, as you all know, there are so many long-term issues. I'm listing some of them. I'm gonna talk about each one of them, but definitely there are numerous. They have seen that the more years pass after the Fontan, as you can see here, there is higher cumulative hazard of complications, including sudden death, heart failure, thrombo-embolism, and others. Why is that? So even though the Fontan allows separation of the systemic and the pulmonary circulation and improve the patient saturation, this is the normal circulation of anybody with normal heart. The left ventricle ejects against the systemic vascular resistance. Then it goes back to the right ventricle, and the right ventricle ejects it against the pulmonary vascular resistance, and it goes back to the left ventricle. This is the normal circulation. However, the Fontan circulation, the systemic ventricle is ejecting against the systemic ventricle. However, there is no second ventricle that ejects the blood to the pulmonary vascular resistance. So as you can see here, the one ventricle that the patient has to eject against both systemic and pulmonary vascular resistance. So there is this continuous afterload on the dominant ventricle, and there is this low cardiac output state that is chronic in those patients. So it doesn't actually adequately replace the absent pulmonary ventricle. There is this low cardiac output and high CVP. So the one really difficult problem is protein losing enteropathy, and you might have patients like that at home, at the office. And that's because of excessive loss of serum proteins into the lumen of the intestines. It can be from GI disorders or lymphatic problems, but we're talking mainly here about the PLE secondary to heart disease. And it happens in about 3 to 15% of patients after Fontan. What happens with the protein losing enteropathy? You lose albumin, so you start having edema, ascites, pleural effusions. You can have intestinal edema, and therefore you can have diarrhea and failure to thrive. You lose gamma globulins, and therefore they are more prone to infection because of immunodeficiency. They lose lymphocytes, and therefore also they can have immunodeficiency. And they lose clotting factors, and they have hypercoagulable state, and they can develop thrombo-embolism. How do you diagnose that? You probably know. So it's low serum albumin and protein, lymphopenia, but the test of the gold standard test is the high stool alpha-1 antitrypsin. So how is the pathology? You have as we mentioned, the Fontan have low flow, chronic heart failure. It can cause inflammation, and this inflammation can release TNF, tumor necrosis factor alpha. In addition to that, the high CVP can cause the vascular venous congestion, and the mesenteric resistance is increased. And both this TNF alpha and the vascular and the mesenteric problem will alter the glucosaminoglycan makeup, and therefore the integrity of the enterocytes is damaged, and therefore they start leaking the albumin, and PLE develops. If you look at the mesenteric Doppler, this is normal. In patients with Fontan, it's not normal. However, in patients with PLE, there is loss of the flow in diastole, and it is like showing you this part of the pathophysiology of this disease, which is the altered mesenteric hemodynamics. How do you treat that? You want to optimize the cardiac output. If there's any problem with the Fontan, you need to take care of it. If there's obstruction, if there's arrhythmia, people tried too many things. They tried fenestration, they tried anti-inflammatory agents like steroids, heparin, sildenafil, entocort, and obviously diet modification. This is the largest study from 35 centers, 3,029 Fontan patients, PLE present in 3.7% of those patients, with a median interval from the Fontan about 3 years. When they looked at the pre-Fontan hemodynamics, everything was perfect. They were not high-risk Fontan. But when they looked at the hemodynamics after they developed PLE, the one major thing is low cardiac output and low cardiac index in those patients. And when they tried to treat those patients, 50% died, 25% continued to be alive, however, with PLE, and only 25% were alive without PLE. And the median age, or 50% of those patients will die within 7 years of the diagnosis of PLE. When they looked at those who had cath, medical, or surgical intervention, outcomes were the same. Nothing improved those outcomes. The only thing that improves those outcomes is transplantation. All patients with PLE and following with the Fontan operation, once they receive heart transplantation, PLE will miraculously disappear. It's very effective in treating PLE. Similar to PLE, we have plastic bronchitis, which is similar to the PLE, except that instead of the enterocytes being affected, it's the epithelial cells of the airways. And they develop mucinous bronchial casts. And I'm trying to they obviously present with respiratory symptoms, sometimes can cause obstruction, and that can be fatal. I'll try to go quickly for the sake of time, but you can see those casts. And this is an example of a cast that takes exactly the shape of the bronchus. And actually you can you can see the alveoli, you can see the lymphatics. when you do the pathology. And the treatment, basically, you have to do mucolytics, chest physiotherapy, but similar to the PLE, everything has been tried and nothing works except for transplantation. The other problem that you know of is liver dysfunction, and because those patients have high CVP and low cardiac output, and they both contribute to the liver dysfunction, you don't need to look at that, but there is a score of liver dysfunction following Fontan that can be from 0 to 10. But what you can see here is that the lower the cardiac index, the higher the score. So it's associated with low cardiac output. And when they looked at 9 patients who had died after Fontan, you can see 4 of them had actually cirrhosis. And when they did pathologies, almost all of them have some congestion. On the right, as I mentioned, 4 of them have cirrhosis, and some of them have even developed cancers. So it's a very major problem. Thrombo-embolism is a problem after Fontan, and it's about 3 to 33% reported rate. And we all know about the Virchow's triad, where the venous stasis, hypercoagulation, and vascular injury are all risk factors for thromboembolism, and they are all present in Fontan patients. This is an example of a patient who had atrial type, all type of Fontan. The atrium is so dilated, and you can see this huge thrombus. You can see here in an extracardiac Fontan where the LPA is completely occluded by the clot. And this is a patient who died, but before he died, they found that there was clot that went to the coronary. So the freedom from thromboembolism is 82%, and the fenestration or Fontan type doesn't matter. There is no proven benefit for any prevention with aspirin, heparin, or warfarin. And as you know, compliance is an issue. However, selective anticoagulation is necessary in patients who are at high risk, including PLE, arrhythmia, large RA, history of thrombus, or thromboembolism. For the sake of time, I'm gonna just skip through some slides. They develop systolic dysfunction, they develop diastolic dysfunction, and they develop arrhythmia. And in some patients, we need to go and do Fontan conversion with arrhythmia surgery. And as you can see, we do ablation of all the lesions that can cause arrhythmia. Then what the end product is, we have converted them to extracardiac Fontan. We treat any residual lesion and we put pacemaker. And the freedom from heart transplantation or death about 90%, and freedom from arrhythmia recurrence is about 80%. Finally, the heart transplantation is necessary in these patients, and these can be some of the most complex patients to do. Future directions, there are lots of people working on doing mechanical circulatory support of those complex patients, but nothing is really standard of care right now. But what we do here, and that's very interesting and exciting, is we do the 3-dimensional printing as we plan our surgery. And this is like a video. You see what I'm doing. What I'm doing here, we image the patient, and then we try to design with this program on the computer that we have what type of conduit the Fontan that I'm going to do. I can move it around, I can make it larger, I can see where I want to place it, and then eventually I can come with multiple options and then send them and to and they can do computational flow dynamics, and they can tell me which model will provide the best dynamics, and this way they can tell me what kind of surgery I need to do in those patients. So this is something that we can actually do now and might improve the hemodynamics of the Fontan. So our Norton Children's Hospital single ventricle program is a comprehensive program, have all the factors that are needed. We do prenatal diagnosis, we schedule delivery, we have advanced imaging as I showed you, we have the state-of-the-art hybrid cath lab where we can do interventions, we have dedicated state-of-the-art cardiac ICU, the Jennifer Lawrence ICU, which is a 17-bed in addition to a 12-bed progressive care unit. We have a strong ECMO team. We have a dedicated single ventricle team, as I mentioned, and the advanced home monitoring. We are part of the NPC, QIC, and PC4 and multiple quality societies, and we participate in their projects, and we definitely can offer heart transplantation and circulatory support to all those patients. My last slide of an example of what it takes. This is the recent patient I did last month when we had a prenatal diagnosis of mitral dysplasia, LV dysfunction, intact atrial septum, and aortic atresia. And this is a very, very rare disease. In the Boston series, only 2 out of 21 survived to 3 months of age. So more than 90% mortality. So we did close prenatal monitoring, we scheduled delivery, the patient was in the cath lab and had a balloon atrial septostomy within 1 hour of life. He underwent Norwood and a partial left ventriculotomy, which is innovative surgery that has not been done more than in a handful of cases, which proved to be beneficial to take care of this very complex patient. He had a challenging post-op, including ECMO for 2 days. However, he's extubated and making good recovery. And we were able, because of this coordinated care and existence of expertise, to allow a patient with a 90% mortality to survive. And I will stop here, and I'm happy to take any question if you have.
Thank you, Dr. El-Soufi. One question is for Fontan patients in the private practices. Sometimes they need dental procedures or other procedures that may cause bleeding. Do the private MDs need to stop their anticoagulation?
I feel like this, they have to refer to the cardiologist, because it all depends. Like, as I mentioned, many of them are only on aspirin. And as I mentioned also, but some of them are on Coumadin and sub-Q heparin. And as I showed, some of them are at higher risk of developing clots than others. So I think it has to be individualized based on the patient's risk factors and what the patient is taking. And I would definitely recommend that they consult with a cardiologist and not taking matters in their own hands, because the cardiologist probably knows more about those risk factors. Okay. If they have arrhythmia, if they have history of clot, you might need to be more creative and probably have them on heparin that is stopped only for a few hours, and that might require admission and inpatient monitoring.
Okay. And also related to Fontan patients, how long are they living now until they need a transplant?
It's a little bit difficult to know right now, because the Fontan, like obviously long-term outcomes we know right now about Fontan is from patients who underwent Fontans in the 80s and 90s. And the Fontan that we do nowadays is different from the Fontan that was done in the 80s and 90s. We have tackled many of those problems, and I feel like our extracardiac Fontan with attention to the residual lesion, if anything, should be better than the old Fontan. What we know about the long-term outcomes of those patients who had their surgeries in the 80s or 90s is probably 80%, about 15 years, are alive and free from transplantation. I'm hopeful that this this survival will improve. But I'm sure also as we get more, as the patient become older, we will be seeing more and more of those patients who are needing to be transplanted. So the longer they survive, the more likely they will fail. But I feel also that the current Fontan is better than the previous Fontan.
Okay, and last question is about patients with BT shunts in the private practices. How concerned should the private MD be about dehydration in patients with a BT shunt that have vomiting and diarrhea? Should they see them in their office, or do they send them directly to the hospital?
I think definitely they need to be very concerned, because those patients don't tolerate that dehydration, and they can clot their shunts, and if they're dependent on that shunt, they can die at home or on way to the office or hospital. So I think it depends on the history that they are provided with. If if it's the patient is looking like the mother is calling and the patient is okay, has been vomiting a couple of times, more nothing excessive, maybe little loose stool but not excessive diarrhea. The mother is just concerned about the fact of the diarrhea but not reporting any major changes in the baby, then maybe I think they should definitely try to see them that same day in their office, but not necessarily send them to the ICU or to the emergency room, I'm sorry. However, if the mother is saying, well, my child is not looking great, he seems like very inactive, has been having this terrible diarrhea for a couple of days, I feel like you need to advise this mother to immediately go to the hospital and definitely contact the single ventricle team who will make all the arrangements. Again, with the home monitoring and like all very close follow-up, hopefully the single ventricle and the interstage monitoring team is already aware of that and they have taken care of that problem without the primary care physician needing to be involved. However, this would be my recommendation.
All right. Thank you very much, Dr. El-Soufi, and this will conclude our program. A reminder to everyone watching, you can get CME credit by filling out the survey, which is located under the chat button on the bottom of your Zoom screen. If you click that, you'll see the survey link. In addition, this will be available again on Norton CME. And next month, we will be having Dr. Jeffrey White provide an update on urology and penile anomalies. So thank you for joining us and have a good week.